All right, so thank you again for joining me. There are a lot of you on, and so I'm very excited to be sharing this information with you. And again, if you're just joining us, we'll be talking about the perinatal periods of risk methodology at a high level. And so let's see here. Here's a brief outline of what we'll be covering today. So again, we'll be talking about PPOR big picture, and then we'll talk a little bit about data requirements, and then the analytic phases of 1 and 2 themselves, and then ways you can complete the PPOR picture. So from a high level, PPOR really is a 6-stage community approach for investigating infant mortality at the local level based on vital records data. And so PPOR, the analysis itself, is just one of these 6 stages. And so the first of the 6 is to ensure that your community and your analyst, is ready. 1 second, we have audio code 4611696. Yep, so Irene, we had a comment box about how the access code is invalid. Can you please try it again? We should have enough space for everybody. Maybe the system didn't catch one of your numbers or something, so do try 4611696 and press pound, and let me know if that still doesn't work, okay? So getting back to the 6 stages, so first step, assure your community and your analytic readiness. And so at this point, you can talk to your community and get their input on the analysis, the issues, etc. And then you conduct the actual PPOR analysis phases. And then based on those results, you develop strategic actions for intervention. And so this is another place where you can talk to your community about the results you get, how to interpret them, how do they feel about it, etc. And also this is a good time to, of course, think about how you're going to implement the program, how you're going to evaluate it, etc. And then, of course, you set all of that up, and then you implement your initiative, and then you monitor it and evaluate your approach, and then you work towards sustainability and hopefully institutionalizing your program so that it's long-lasting. So PPOR is a simple analytic framework, and it provides steps for investigating fetal and infant deaths at a local level. As you can surmise, it connects data to action, and then it uses all available information from vital records and other population-based data sources. And so for PPOR itself, we will use vital records, but to complete the PPOR picture, you can always supplement with different surveys, different national sources of information, etc. And then, of course, with community involvement, it helps you and your community prioritize areas where you can have a measurable impact on your birth outcomes. So why do we use population-based data? I know that there are really great programs out there with their own data collection. There's WIC, home visiting, behavioral health services, Medicaid data, and all of that's great, but it doesn't necessarily encompass the whole population. And that is the benefit of using something like vital records, because it includes everybody, right? And so when you start with vital records data that includes everybody, you can always go back and reinforce those data points with additional data points from WIC, from behavioral health, home visiting, etc. And this kind of is, I kind of talked about this, but it includes all babies, and the deaths from vital records are not a random sample of live births, and studying only infant deaths results in bias and does not provide a representative picture of the population. So the components of the PPOR Phase 1 and Phase 2 analysis are shown here. And so in the first phase, we determine the fetal infant mortality rates in each of the boxes. And we'll get to the boxes in a minute, but PPOR boxes are divided into 4 different periods of risk. And so we calculate the infant mortality rate for each of those periods. And then we share that with the community, of course, get their feedback, their input, and just keep them in the know about their local data. And then compare it to a reference group. And we'll talk about that a little bit more. So for Phase 2 of PPOR, we use the rates that we found in phase 1, and then we look at the period of risk with the highest excess mortality rate, and then determine what risk factors are involved with that period of risk. And then you can calculate population attributable risks, and I'll talk about that as well, to see the impact of lowering the risk of death, or lowering the prevalence, I guess, of the risk factor in your community. And then you use this information, of course, to inform your programs and share with your community, and hopefully, drive some political will. That'd be nice. So at the bottom here, that's the map, or the periods of risk that I had mentioned. So PPOR delivers a short list of areas for intervention that are likely to have an impact on infant mortality disparity in the study community. What I like about PPOR is that it also empowers your community, and it helps them feel like they have ownership over the data, because it does represent them, and these programs are for them and involves them directly. And so this is a good way to really involve them in the process. And then if you find through your PPOR analysis that maybe your data quality could be better, this could be motivation to improve that. This could be, shown as a case where, maybe we need to standardize the way we record things, or improve the coordination between different staff members who are inputting the data, or something along those lines, to improve data quality. And so with this PPOR map, you can see that, actually I think, yeah, here's the bigger one. So these are the 4 periods of risk on the PPOR map. The first box, the big blue box, is called the maternal health or prematurity period of risk, and that includes the babies who are less than 1,500 grams at all of the different ages of death. And then for the second row on the bottom, the pink, yellow, and green box, they represent the babies who are 15 or more, or 1,500 or more grams. And then these periods of risks are divided by the age at death. And so we have fetal deaths, and then we have neonatal deaths that are 0 to 27 days after birth, and then postneonatal is 28 to 364, anything under that 1 year. And so when I talk about PPOR map or periods of risk, this is what I'm referring to. So when we go through the periods of risk, we calculate the excess mortality rates. We get to a point where we see some boxes have higher excess mortality than others. And so the advantage of PPOR here is that instead of looking at all 4 periods of risk, we can specifically look at the box with the highest excess mortality rate, and perhaps that is the area of opportunity where we'll have the most impact for improving birth outcomes for women. And so, for example, if you find that in your community, newborn care has the highest excess infant mortality rate, then you can look at perinatal management, pediatrics, hospital data, et cetera, to see what's going on in your community specifically, instead of looking at hospital data, but also looking at SIDS or prenatal care or chronic disease. It's a more concerted or more specific thing to start out with, but that doesn't necessarily mean that you only have to look at the risk factors for the yellow box, because if you are curious about any other risk factors that might be tied in or related somehow to the yellow box, then feel free. But PPOR gives you a place to start at the very least. And please let me know if I'm going too fast or if something's unclear. Press *7 to unmute. Okay, so moving on. So of course, naturally, the PPOR analytic phase has data requirements. And as I mentioned, we'll be using vital records data, which includes linked birth death files and fetal death files. And as I had mentioned before, you can gather additional pieces of information to supplement your PPOR findings. And we have a question in the chat box. Yes, this is being recorded, and I'll send it out to everybody who registered, and I think we'll post it on our website or send it out in an email blast to all of our members. Thank you for your question. So going back to the requirements for PPOR. So, of course, with the after you've gotten the right vital records data, preamps data, surveys, etc., you should have a person to do the analysis. And it's kind of an obvious thing to say, but there are places that struggle with epidemiology capacity, either due to staff turnover or just familiarity with the PPOR method itself. And also, if it helps, we have journal articles that I thought were very helpful. And so if you need those, we'd be happy to send those out at any time. And then, of course, some statistical software package like SAS or maybe Excel to carry out this analysis, because it can become a little bit, if your population is bigger, it can become a lot. So it makes it easier if you have something like SAS. So moving on, from vital records data, you can get demographics, of course, like maternal age, race, marital status, residence. You can also get a little bit about her medical history, if the baby was premature, if it was elected early term delivery, and then other pieces of information. And of course, and again, this covers everybody, so this information should be ideally complete for everyone. So why do we include fetal deaths? It's not, we know that sometimes the recording of fetal deaths can be different between jurisdictions, between coroners, etc. But fetal deaths are important to families. We don't want to exclude these very important cases. And they do provide information to our PPOR methods and our interventions. And there are almost as many fetal deaths as there are infant deaths, and they can provide us with even more information about infant mortality in the community. And so PPOR really just uses all of the available information to investigate your fetal infant mortality at the local level. And so PPOR answers the question of what rates should we expect to see in each period of risk. And to explore that question, PPOR uses a study or a target population and compares that to a reference population, which is a real population of mothers, usually living in the same county, same jurisdiction, same area, that happen to experience the best in the birth outcomes, like low fetal infant mortality rates, low prematurity, etc. And community input is very important here, because your community should be able to have a voice in who they are compared to. Does that make sense? So if you want to compare, your community to non-Hispanic white women who have at least a high school degree, you bring that up to community, and maybe they are more interested in being compared to non-Hispanic white women who have at least a bachelor's degree. Or maybe your target population is Latina women who want to be compared to other Latina women who differ by another demographic factor. And so, of course, reference groups are selected based on demographics and social factors, not on behaviors or health conditions. And as you can see at the bottom of the slide, a typical reference group is non-Hispanic white women with who are 20 years old or older with college education, and usually it's who reside in the same community, but that is up to you. So we got a question in the chat box about fetal death. So what I mean by fetal death is when there was a death that occurred before the baby was born, but it was also after 24 weeks. And so that kind of gets into exclusion criteria, which I will get into in about 3 slides. Okay? So let's get started. Let's talk about analytic readiness and phase 1. So for what I mean by analytic readiness, you gather your data. So you input your data requests, and you think about all the different variables you'll need, or for the variables you'll need for PPOR. And if you're interested or curious about anything else, maybe it's best to submit it in one big data request to your state or to your the person who controls your data. And that way you don't have to submit one application, wait, and then submit another one, and then wait some more. So maybe it's in your best interest to just think ahead a little bit and request everything at once. And as I had mentioned, orient your analyst to the PPOR methods. And so, have them read the articles, rewatch any of these webinars, If there's something you don't understand, you can always reach out to us at CityMatCH, and we'll be happy to help. And then, of course, I wouldn't be doing my due diligence as an analyst if I didn't remind you to check for the degree of missingness in your data. And what I mean by that is you have to look at how many pieces of information are missing from your vital records information. Like, are you missing a lot of information on mother's education? Because that would be important when it comes to creating your reference group, right? It would artificially lower rates if you have to eliminate a bunch of cases due to missing education information. And so ideally, 5% is the bar that we have for degree of missingness. We got a question. Let's see. My state requires, so somebody's state requires IRB approval for releasing data. We do not have an example of IRB applications for PPOR, but we would be happy to work with you on it. Maybe we can give you guidance on the kinds of language to use, justification kind of language, anything that might be helpful.
This is Carol Gilbert. I just wanted to mention that most places that use IRB to do this request an exemption. It should be exempt because it's not research. It's usually considered public health surveillance. So it can be a simplified process.
And that was my colleague Carol. She's the other analyst at CityMatCH, and so she's been listening in. And you'll hear her add any comments or any other pieces of information as they come up. But yes, we can certainly help you with that. So you can email us, give us a call, and we can work with it or work with you on it. And yes, these slides will be made available after the recording or after the webinar, and I'll send out the recording too. Okay? And I know we've talked about community input, but it is very, very important to include your community. Because they should have a say in how they are represented, how they are compared to other populations. So as you could surmise, there is an impact of missing information, and so of course, like I mentioned, it biases the reference group, and then it also can bias your phase 2 analysis. If you have missing information on cause of death or missing information on certain risk factors, that can change the prevalence that you get when you're calculating the PARs. So here is kind of when we go back to the fetal death question. And so for PPR, we have exclusion criteria, and we exclude the cases if they are less than 24 weeks, less than 500 grams, or if they are unlinked, and if they are missing weight or gestational age up to 5%. And so sometimes we can impute that weight or gestational age, but typically, if it's 5% or less, we can just exclude it. And we exclude the fetal deaths that are less than 24 weeks because the reporting gets really hairy and it's inconsistent, basically unreliable for analysis, and it's kind of the same for 500 grams. And then for typo there. For phase 1, you'll need at least 60 fetal infant deaths in each group and about 5,000 births over the same period. And for phase 2, you'll need more. There isn't a set number, but typically we talk about around 200. And that kind of helps you work through the numbers and the different calculations in phase 2. But we also understand that the different analysis methods like the Kitagawa, which we'll get into, or looking at the infant health period, it limits the number of cases you look at in phase 2 just because those populations or those risk factors and outcomes are rare. We got a question about if the state no longer links birth and death files, could we do it ourselves? I'm not sure that we could do it ourselves, not like CityMatCH, but I'm not sure if locals can do it. But I would be surprised to find that a state didn't link your birth and death files.
Yeah, the states all do link their birth and death files, so if somebody's telling you wrong, that they're all submitted to the federal government as part of the national vital record system. So maybe we need to help you talk to the right person at your state.
Yeah, so I would double check just to make sure that they do or they don't link those files, because it'd be a lot easier if they did and you could just request it, right? So let's see. For phase 1, basically what you do is you categorize the deaths into each of the boxes. So based on their age at death and their birth weight, then you can put it into the blue box, pink box, yellow box, green box. And then you do the exact same thing for your reference group. And then to get the excess mortality rates, you just subtract. You subtract the study population from the reference population, and then you get your excess mortality rate. And then, of course, you identify the highest, the box with the highest excess mortality rate, and that would be your place to start. So earlier I talked about that 5% threshold. If you have more than 5% missing, you can always think about imputing. And so that is basically just a way of using an educated guess or an estimate based on a different variable. So let's go to the next slide. So for live births, if you have gestational age and it says less than 22 weeks, you can assume that that also means that that case was less than 500 grams. Or if it was less than 31 weeks, then you can assume that means less than 1,500 grams. And then for fetal deaths, it's basically a similar pattern. So if the fetal death was less than 24 weeks, that also probably means it was less than 500 grams. And we've learned that that would be excluded from PPOR. But if it was less than 32 weeks, that probably means that it was less than 1,500 grams. And so this is what we do when it's more than 5% missing information. And that kind of is a way to avoid biasing your information. So this is the same PPOR map, just laid out a little bit differently to kind of show the logic behind excess mortality rate. And it really is just subtraction. So you take 5.7 minus 1.8, and you get 3.9. And that tells you that there's an excess death rate of 3.9, or 3.9 excess deaths for every 1,000 live births and fetal deaths. And you can do that for each of the boxes. And then for each population, so for the target population and for the reference group, you can add the totals in each of the colored boxes to get the total infant mortality rate for each of those populations. And then you can subtract that as well, if that makes sense. So if you add, for the target population, 5.7 plus 2.9 plus 1.8 plus 2.7, you'll get 13.2. And then you do that for the reference group, and then you subtract the 13.2 from the 4.7 to get 8.5. Simple math here. It's really great, not rocket science at all. Okay, so then we're moving on to phase 2. A lot of people like to stop at phase 1, but please do not. It was very helpful to go into phase 2, because this is where you get to that those actionable stages of looking at risk factors and targeting your intervention. So for phase 2, you take the periods of risk with the highest excess mortality, and then you look at causes and areas for intervention. Okay, so you look at risk factors, you look at causes of death, and then you estimate the potential impact of those risk factors. Oops, did I go back? Nope, so this is just that slide again for a reminder. These are the different maps, and then you subtract and you get 3.9. And then in this specific example, the period of risk with the highest excess mortality rate is the blue box, right? And so let's say this is in my jurisdiction and these are my results. So apparently I need to be concerned about maternal health and prematurity. So if that's my area of concern, we typically do something called a Kitagawa analysis, and this is only for the blue box. You do not do this for any other period of risk. But for Kitagawa, it helps you determine if your problem is birth weight distribution or if it's birth weight specific mortality. So are you having a lot of premature babies, or are you not taking care of those premature babies? And then based on what you find in Phase 2, Step 1 of Kitagawa, that determines what kind of risk factors you look at. And so if you're having too many premature babies in your community, maybe you need to look at maternal stress or preconception care, access to prenatal care, maternal infections, etc. Or if you have a lot of premature babies that are not surviving, then maybe you need to look at hospital-type stuff, like are they being referred to Level 3 facilities? Are there neonatal specialists available? Like, are we taking care of these vulnerable babies? The difference is nuanced, but it's there, and it's important because it changes how we approach the problem. And so, for an example, you can find that 91% of excess mortality in your blue box is caused by too many very low birth weight babies. And so this is what Kitagawa would give you, and then you determine how to prevent low birth weight births. You do that by looking at risk factors. And so here, this is just an example of looking at different risk factors for prematurity. So smoking, lack of prenatal care, overweight, obesity. And so just by looking at these different risk factors, you can start to see, where there might be opportunities for action. And so I guess it would be Step 3 of the Kitagawa analysis, or no, you can do this for any of the infant health periods. But you can estimate the population attributable risk percent. And so what you're getting at is if the risk factor for very low birth weight births among your community could be reduced, or among smokers in your community, could be reduced to the risk among non-smokers, how much would the overall very low birth weight births be decreased in the population? So if you do your PAR analysis, it gives you an upper limit of the benefit if we address this risk factor. So this is estimating the impact of your work. And my next slide has the formula. I talk about it a little more. But this is just kind of getting back to looking at risk factors and then kind of seeing what floats to the top as the most as having the most impact in your community. And so this is the population, or the the formula for PAR percents. And so you're looking at the risk in your population minus the risk in your non-exposed population, and then dividing that in the risk in your population. And I know we said it'd be high level, so I'm not going to dive much further into that, but basically, based on your results, you can say that, for example, if women with the previous preterm birth could have the same low risk as women without, we would reduce very low birth weight births by about 8.7%. And so, once these slides are available, if you're really interested, you can work through the table and look at the formula on the bottom left corner to see how I got to that 8.7%, and then the bottom right is how you would interpret that number. And so you would do this for a number of risk factors related to whatever your period of risk is with the highest excess deaths, and then you'll see that there are a few that float to the top that have the highest PAR percents. And so this, by addressing these different risk factors with the highest percentages, you can have the most impact. And so we see that birth spacing, is a pretty big issue, and so maybe we need to address that in our community. Or education is a factor, and so maybe that means, health literacy is something that could be improved, or just access to information for teenagers, etc. And so this is the benefit of doing the PAR analysis and just PPOR in general, because then it narrows down your list of risk factors to look at. And so again, this slide says the same thing. So these were the three with the highest PAR percents, and you can compare it across the different groups. So if you look at, let's say, the target population was among Black women, and you can see that among Black women, certain risk factors were prevalent, way more prevalent than compared to the reference group, and then you can see what the PAR percent is. And so what the impact of addressing birth spacing would be if you reduced it in your community. Let's see here. And so sometimes, in a lot of communities, the blue box is the issue, but sometimes the green box can be as well, or they can be in second place as the highest excess infant mortality rates. And the analysis methods for examining the infant health period is different. And so if you remember, that Kitagawa analysis is only for the blue box. Now we're talking about the green box that includes post-neonatal deaths that are 1,500 or more grams. And so these are the babies that died 1 month to up to 1 year after their birth. And so with this, you can look at causes of death, right? And so you can see how many were due to injuries, how many due to SIDS-SUID, birth defects, and then that, again, determines what your interventions are or what risk factors you'll look at. And then, so you get the causes of death from the death certificate, and what you'll get is ICD-10 codes. And we learned yesterday that ICD-11 is coming or has been released, but these are ICD-10 codes. And this is not exactly helpful to, it's not practical to look at. So, X97 doesn't really mean a whole lot to me. I don't know what that stands for. Q999, not exactly helpful, right? And so for the infant health period, once you get these causes of death, you can group them together based on their based on their chapter. So for like SIDS-SUID's death, I know it's R95, R99, W75, and if you group that all together and you know that those are the SIDS deaths, then you can look at them collectively in that way. We got a question. So for going back to the PAR, thank you for your comment. I want to emphasize that for the PAR calculations, it is not determining causal. They are possible risk factors that are related or associated to different birth outcomes. You're not determining cause here. Okay, it's just a relationship. Correlation does not mean causation. I could not stress that more. Thank you for your comment. So going back to infant health, so you group them based on their chapter, and then you look at, again, the potential impact of reducing and removing those risk factors. For the pink box, the maternal health box, we don't have a specified protocol for this one or the yellow box, but these include the larger stillbirths. And for this group, you can look at things like maternal weight, again, birth spacing, prenatal care, smoking, weight gain, etc. And you can also supplement that information with information from PRAMS. That's a really good survey. Tobacco surveys to look at smoking patterns, smoking behaviors, and other different population-based data sources that could support your vital records data. And then for the yellow box, it's the newborn care box. And so these were the babies that were 1,500 or more grams who died within that first month. And the issue here would be things like perinatal management, hospital care, neonatal care, pediatric surgery. And so to examine this yellow box, you can look at hospital-based data, so HCUP data, and you can look at the level of hospital, the hospital-specific mortality rates. If it's one hospital that has high mortality rates in your community, higher than other hospitals, or maybe it's the systems thing. And it might be helpful to involve a neonatologist here to really help interpret this more clinical information, to turn that into practical public health information. And so again, here we don't have a protocol like we do for the blue box or the green box, but there are ways to address and examine these different, these two periods of risk, this pink box and this yellow box. So for, again, just to bring it back home, this big picture, we eliminate through PPOR, we find out what the risk factors are, and then we work to eliminate those risk factors. And then we also know which ones are not likely to have an impact in the population. So you know that if you address one, it would be more impactful than another one that doesn't really apply to your community. And again, you'll find a few contributors that are related to the problem. Again, it's not a causal relationship. And then, of course, at the end of PPOR, we get a short list of risk factors that we can look at and track over time using vital records data. And I see a comment in the chat box. Yes, so I did just throw out an example for going back to the, let's see, where is that cited? Going back to the green box, that infant health box. I just threw out the ICD-10 codes for SIDS-SUID just because I knew what those were and that they're typically examined together. But yes, there was a comment about how the interventions for R95 and W75 deaths are going to be very different, and that is up to your local expertise. So obviously you would know more about SIDS or SUIDs specifically than I would, and so that is also something worth noting, because then that gives you more reason to involve subject matter experts and different partners in your community who might be more familiar or work day to day with these different issues. Thank you for that. Let's see here. So we've gone through the blue box, the green box, and the pink and the yellow box. And so that was PPOR basically using your vital records data. So now to complete your picture and to supplement what you found from PPOR, we can go into the different sources of information, other sources of information. And so we've talked about vital records data and their strengths that include, representation of everybody, and it's collected every year, and their common variables. And it's a good objective way of looking at things because it does represent everybody, and it's a standard way of collecting this information. But also it comes with limitations. There are a limited set of risk factors or variables to study. There are some jurisdictions that have small populations, small areas, and so that, that comes with all the challenges of having low N, as we call it, or small numbers to work with. And sometimes it's not exactly accessible, and so requesting that information might take a long time, or maybe there's just so many barriers and that keeps you from moving as quickly as you want to. But that's okay. These things take time. And then, of course, again, this does not show cause and effect, right? There are other sources to tap, like your census data. I know the census website is pretty good. You can create different tables, different maps even, and you can look at a whole bunch of risk factors, including the census. I also include the American Community Survey, and that's more socioeconomic information, and so it's always a good resource to tap. And your community organizations or maybe your health department has been collecting information from local surveys. That's something you can include. PRAMS information is always very helpful when it comes to these types of things because it captures the maternal experience, and it talks about maternal stress, depression, different risk factors, the things that were talked about in prenatal care visits if they had prenatal care visits, just a lot of different pieces of information that could really help support your PPOR results. And then, of course, BRFIS data and just a bunch of other types of state-specific questions that might also differ between states, just because states have different cores, or not different core, but different supplemental questions to their BRFIS. But it's a good thing to look at, and that is also something you can request from your health department, from your state health department. And like I've talked about before, always include your community voice because they would know better than we as public health professionals the issues going on in their communities, right? They know what they need. They know what they have experienced. They know people who have experienced these things, and they could probably tell you a lot more than just looking at, survey data could. And, of course, case reviews. If you have a local FIMR, that could be a great source of information, especially, again, if there's that maternal interview. And then you can also always look at research findings, the literature and PubMed, just to see what other folks are doing and what they're finding. And then if you take this in a collective impact kind of approach, you can talk to other community organizations to see what they know as other stakeholders who might be working on the same topics. So there was a question in the chat box. When looking at risk factors contributing to deaths in the maternal health period, are there additional analyses that can be done to really drill down to the factors that are contributing most to the excess deaths? Carol, do you have any thoughts?
Well, that is what we're doing with vital records, and vital records is the source that has the most. But yes, that's what this slide is about, the other sources that you can do to drill down. Was the question about sources or methods? I don't see.
Methods.
Well, you can, yeah. There's nothing magic. You can use something like logistic regression if that's what you're thinking about. It doesn't. I would prefer to use the literature than do a logistic regression on this local data, because you'll find you have some missing data, and the vital records data is not as good as the research usually is when trying to investigate cause and effect. But really go from this broad strokes data that you can get from your vital records and your other population-based data sources, gives you kind of broad strokes, and then drill down using the literature. I mean, that's what the scientific research is for, is doing that cause and effect connection. Does that help answer the question? You're not doing research here. You're doing surveillance. The research has been done. Well, not enough of it, but some of it has been done. Well, if it doesn't answer the question, text some more.
She says yes, that makes sense.
Okay.
Thank you. So let's see. Right, so speaking of other sources, I had mentioned FIMR with their case review data. It is good for qualitative information, and it's often a really good supplement to really put the humanity back into these numbers that we've been looking at, these spreadsheets and statistics. The qualitative information gained from things like a FIMR case review would be very helpful. That also comes with limitations, despite its large benefits. There are a small number of cases that are reviewed, and it is non-random, and it should not be interpreted as representative of the population. But when you're talking about, maybe you're doing some advocacy work or storytelling and sharing this information, the information used from FIMR could really bolster your, not necessarily your argument, but it could really support your point. And as Carol had mentioned, research can kind of get you closer to determining cause and effect, but also just kind of see what other people are doing, what they're finding, and if your findings are consistent with their findings. And then, maybe there are also research findings somebody published about their project and maybe how it worked out in the end in terms of evaluation data, measures, et cetera, something that you could use to inform your work before you implement your work. Of course, research has some limitations. Research can often be costly and slow, and so that makes it difficult to replicate. And sometimes research focuses on special populations, and that may not be so relevant to your community. Excuse me. And so community voice. I know we've talked a lot about this, but it is important, especially to us here at CityMatch, that you include people who live in your target community. Like I had mentioned before, they have that firsthand lived experience, and there really is no substitute for that. And it also helps, one, build trust between you and your community, and two, it encourages community buy-in into your programs, and that can help make it last a long time, get more people to participate in whatever program you're thinking of implementing. And so if they talk about their great experience, how it addressed their needs, and things just spread by word of mouth, maybe you'll get more people at the table and more people who will show up because they now know that you're trying to improve these things with their input and with their help. And I had mentioned kind of a collective impact approach earlier. It's really I think to everybody's benefit to include many other community organizations, community leaders, stakeholders from different sectors, right? Because public health issues were not caused by a singular entity. So these issues that we address, like poverty, housing, education, etc., they are public health, but it makes a whole lot of sense to also include the people who are working with education every day, who know more about how the system works and who interact with these different policies and all these different factors that are involved with education. The same for transportation, same for housing. And then your faith-based organizations would be really helpful because they are, your foot in the door with the community, right? And so it would be really great to involve many people because, also, it sets up your network. So you can have a whole network of people to talk to get help from, maybe share resources, share knowledge, share expertise, and it would just only benefit you in the end, I think. And so I have some final notes. When you're sharing this information, and we'd be glad to talk to you more about data sharing and data communication and message framing, but I didn't want to get into that too much today. But do be mindful of how you phrase things. Think about the purpose of your presentation or your report or what you're trying to do, and think about who your audience is when you're sharing this information. How do you make it more digestible, make it more approachable, and more accessible to your audience? And then when you're talking about these different risk factors, avoid victim blaming. Think big picture. Like if you're talking about prenatal care, you think about what barriers are there to obtaining prenatal care. So is it, a lack of timely transportation where a woman needs to get on a bus, but the bus doesn't come on time, and then if she misses her appointment, she gets charged or canceled, and then she can't afford to get those cancellation fees because the bus was unreliable, and so she just doesn't end up getting the prenatal care that she wants, right? And so that's big picture systems level thinking that might be more impactful than trying to fix things downstream. But that's not to say that downstream interventions aren't important. So we do like to look at big picture upstream and also downstream, right? And so I think that about covers it. The Frameworks Institute is a really great resource. Their website has a lot of information on how to frame messages and share information. And this is generally for advocacy type work, but it could also help inform the way you talk about data and information in general, maybe to the public or to different audiences. And I think that about covers it. So feel free to chat in any questions. I do see that we had one about the quality of fetal death in their state or in their jurisdiction, and it has considerably hampered PPOR analysis. So what is the experience of other states with this data set? You know what? We can throw that out to the other attendees. So if you had tried to work with PPOR or had tried to perform a PPOR analysis, but your fetal death information was a hindrance, you can press *7 to share your experience and how you mitigated that, or if you mitigated that and how you created a workaround. *7 if anybody has any experience with that.
So we do have a lot of states where there's bad missing data on the fetal deaths, high rates, especially of missing maternal education. The other big problem with fetal death certificates is that some states do a lot of autopsies and others don't, and autopsy makes a big difference in what's what's recorded on the fetal death certificate, what the causes of death are. So, you noticed in the protocol we don't really even use cause of death on the fetal death data. We just skip right over to risk factors. But in order to do a PPOR analysis, you feel free to go ahead and chat in questions. I'm just babbling while people think of their question. But in order to do PPOR, you need to have the maternal information. You need to have the maternal education, if that's how you define your reference group. And if education is what's missing, if you're missing 20% of the data from your fetal deaths, you're going to be missing some moms who should be in that reference group and who won't be in the reference group. So it will artificially bias down your deaths in the reference group for that. So one way to get around it would be to not use education as a criteria in your reference group. You may be able to use insurance by Medicaid as another way to define low socioeconomic status. Or you can just not use socioeconomic status as part of your reference group. That's a possibility. Your state data may have a lot of possibilities of what you can use. It may actually have income. So I don't know whether any states do. So that's one way. Another way is if there's a lot of data missing from the fetal death certificates, you can do a PPOR-ish method. You can still do the kinds of comparisons that PPOR does, but not use the fetal death data at all. You can do even a Kitagawa-ish. You can do the Kitagawa calculation for infants only. It'll make the blue box be less important because the fetal deaths add a lot to that blue box. So it will change your results. But the whole idea of a reference group and excess mortality and comparing the two groups, that can still go on even if you don't have fetal deaths. And by the way, there's a lot of communities that don't have enough deaths to do a full PPOR, but they can still use that concept of the reference group and excess mortality to help guide their activities. They can still do population attributable risk and comparing prevalence of risk factors. So these concepts are kind of universal epi concepts, and you can use them in a lot of ways. Are there any more chats? Maybe we could post that. We could post links for those or email them to people. We have links for those presentations.
Have I been on mute this whole time? I think I've been on mute this whole time. I'm sorry. But we had a question about the institute that I mentioned. It's the Frameworks Institute. And they do have information on framing messages and how to share information. But they also include information on things like implementation science and different ways of implementing information, sharing information. And then, as Carol had mentioned, we can compile maybe a small list of things that we find or that are pretty cool on their website to share with you, because it is really interesting, and it does help when you know how to communicate with people instead of just hitting them all with the numbers at once. There's a strategic way to make it a little more accessible and digestible. So we had another question about an intervention for increasing access to smoking cessation. And so what data points to inform your project? So to look at smoking cessation, you can, I wonder if there's like a local tobacco survey. So CityMatCH is located in Omaha, Nebraska, and I know that our state has a tobacco survey that looks at smoking patterns, how often they smoke, how heavily they smoke, when they started smoking. You can also look at Burfist for that information. Let's see what else. PRAMS has a couple questions on smoking before and during pregnancy, and there's a calculated variable for change in smoking behaviors during their pregnancy. Let's see what else. I think vital records should have smoking information as well, but that might be underreported. But that is another thing you can, another source you can check out and then assess it for missingness. And then, maybe your state or your local politics has policies on, point of sale for tobacco, and just different types of information that they use to support restrictions on tobacco. I know that at one of our local universities, there's been research on point of sale and just kind of looking at how ads are placed, where they're placed, just to kind of get at a possible intervention of maybe we need to change something locally where the advertisement isn't right by the register, and so encourages people to buy cigarettes or whatever. So I hope that helps. I'm just kind of brainstorming here, but there should be some other pieces of information to really support your intervention or your quest in addressing smoking during pregnancy. So that's very important. Let's see. Yep, so I will be sure to send this recording. I'll send the slides, and then it might take me a little bit to compile a list of other resources, but I'd be happy to do that. I also have a working list of resources for communicating data, visualizing data, like different places you can go for creating infographics or maybe even online dashboards. That sounds kind of cool. Yeah, so I can share any of that, and if you have any questions, I can just email us, and we can try to help you however we can. So there was one slide where I had talked about the exclusion criteria and the minimum number of cases. So there was a typo. In the slide, the bottom here says phase 2-need. That's not an error on your screen. That's an error on my part, and I apologize. I was in the middle of typing something, and then I got distracted. But yes, for phase 1, you'll need at least 60 infant deaths in each group, and then at least 5,000 births over the same period. And this is really just so that your numbers are reliable. Because if your numbers aren't reliable and they're small, they'll change a lot from year to year, and so whatever your rates are for each of the for each of the periods of risk will change year to year, and so that really hinders your work or the impact of your work, right? And so if you don't have, say you're looking at 2014 data and you don't have the 60 that you need, you can combine years, and we really set the limit at about 5 years, so don't combine more than 5 years of data. And do make sure that you pay attention to any big changes that might affect the way your data is recorded or the way your data is reported. So maybe there was a change in the birth certificate or different policies that have affected vital statistics information collection. And then for phase 2, we had talked about having more than 60. The more the better, maybe about 200. And that is with recognition that, things like Kitagawa for that blue box or the green box, the infant health period, would limit the number of cases you have for phase 2, but that doesn't mean you don't look at it, right? You don't throw the baby out with the bathwater. You do what you can with what you have, with all of what you have. And so I hope that helps. And let me know if there's something that needs to be clarified, or if anybody else has any questions, feel free to press *7 to unmute yourself or type it in the chat box. I'm keeping an eye on that. So I hope this was a high enough overview of PPOR. I know we got a little bit into the weeds and talking about the PAR formula and stuff like that, but I included it just so that you kind of have an idea of where I'm coming from. And so, I hope this gives you a better understanding of the PPOR process and what the benefits are, and of course the importance of your community in this work. So we are thinking about having a follow-up to this presentation, or a different, along the same vein, but kind of different presentation about data, data sources, data use, communication. And so there will be a survey after this. You'll get it in an email from us. If you entered your email into the registration. We can send that to you, and so you can tell me what you need, what was helpful, what needs more explanation, and we'd be happy to have another one of these types of webinars to kind of talk about the issues that are practical to you and how it might help you in your work. So just let me know and fill out that survey, or you can email me personally. Our contact information is usually on the website, or you can email the CityMatCH account, and it'll get forwarded to the right person. And yes, this recording will be made available. I'm not sure how soon we can get it uploaded to YouTube, but at the very least I can get you the recording from our ReadyTalk service, and then I can send a YouTube link out to everybody. So that's a little bit easier to watch. Let's see. So let me know if there are any other questions. I know we're a few minutes over time, but just in case, I wanted to give some opportunity to see. There was a question about what can we do with communities that have challenges with deaths less than 24 weeks gestation and or weighing less than 500 grams. That's a good question. Carol, you want to?
Yeah, Bill Sappenfield, who invented PPOR, has always said to add another box, and that's a good idea. We think that recording has improved, and there may be some places that have consistent reporting for those tinier babies that aren't usually included in PPOR because of the variation in reporting. But as long as you're willing to use it carefully and realize that there might be differences in recording in some of those. In some communities, some hospitals don't record these smaller, tiny babies. So your reference group recording might not match the recording for your whole community or your target population, and that would cause a bias in your results. So as long as you're aware of that, go ahead and do a additional box, make a 5th PPOR box, and go through a similar process, subtract to get the excess mortality, and look at the risk factors. One thing, though, that typically happens when communities do this is that it's a lot of the same risk factors and a lot of the same results that you get with the blue box. It does add numbers, but the blue box seldom has a problem with small numbers anyway. So it doesn't usually make a huge difference in what your conclusions would be if you add that 5th box. But you can go ahead and do it. I realize it's a terrible thing to throw away information, so give it a try, but use it carefully. Make sense?
Thanks, Carol. And to add to that, I didn't mention this specifically, but for the blue box, all of the different ages at death are merged together because, like Carol had mentioned, the risk factors and stuff are pretty similar across those different ages of death, and so that's why it's grouped into one big blue box instead of the 3 separate boxes you see in the other row. So yes, I hope that answers your question. And we had another question about a list of variables that would be best to include in your request to vital records. Yeah, so it's very common that vital records folks require specific variables and then exact reasons why you're requesting these variables or what you're going to do with them, and we can help you with that. We do have a list of risk factors to look at, and so we can work with you to see which ones would be available to you or which ones you would like to include in your request, and so we can do that anytime you're ready to prepare that request.
Yeah, and states do vary in terms of what's in their vital record system, so you may have things that are not on our list, but they're still important. So we can discuss those with your variables that you have available with you too.
Okay, are there any other questions? Okay, well, we are 7 minutes past time. I want to be respectful of your calendars. So thank you all for joining us on this webinar today. And as I said, we we hope to have kind of like a mini series about data and communication about this. So let us know what you need, and we can see if we can make another large learning network webinar that's available to everybody. And then again, these slides and this recording will be made available. So I'll let you know. It might take a couple days, but I'll definitely get it out to you, and then we'll see what I come up with in terms of a list for resources, okay? All right. Thank you, everybody, for joining, and we hope to speak to you soon.